Welcome and thank you for joining us today live, or if you're on the recording for episode 20 of Dr. Jeff Talks About Sex and Intimacy, Prostate Cancer. It really means so much to me that you are here and took time out of your busy life to learn more about this really important subject. We are on social media. If you don't know, we're on Facebook, we're on YouTube, we're on X, you name it, we're out there, we're on it. And so please go to your social media site. If you happen to be a Facebook person, please follow us, because when we have enough followers, we will stream live there rather than just the recordings, but you can watch us on any of your social media sites. You can also go to our website. If you go to the website, you can watch previous episodes with all the awesome, incredible guests that we've had since the beginning of January. Lots of good episodes. You can go to the calendar and see what's coming up next each week. And we have programming already in there through July and wonderful, wonderful guests. So please go to the website. Also, you can listen to us in your car or wherever you are on your favorite music streaming service. If you like Spotify, Amazon Music, iHeartRadio, whatever you like, you can listen to us as you roll along. Audio is there, and we are on your favorite music streaming sources. So join us. I want to remind you once again that all are welcome. Whatever your sexual orientation, whatever your gender identity, or whatever your relationship style, you are completely welcome here. And we are so glad you are joining us. And I hope you learn a lot from what we talk about this evening. All right. So what's the goal of the podcast? We created the podcast, and the only goal, it's very simple. It's to enlighten and inform you, to give you scientific evidence-based information to help you make good decisions to improve sexual health and to enhance your loving relationships. That's it. That's the goal. So today's podcast, well, we are addressing a critical topic in men's health. June is Men's Health Month. We're almost there. So to kick it off, we're a little early. We're going to talk about prostate cancer. It's the most common non-skin cancer in men, yet many men know very, very little about it. If you didn't see, even our last president, President Biden, was diagnosed with prostate cancer, and that's been a hot topic in the news. Today, I'm joined by Dr. Brian Helfand. If you remember last week, Dr. Glazer went over prostate health, and we talked just a little about prostate cancer, but mostly about prostatitis and benign disease. Tonight, we are zeroing in on focusing on prostate cancer with Dr. Brian Helfand. He is a leading urologist, and he's a prostate cancer specialist, and he's here to discuss the latest insights and advancements in prostate cancer care. Dr. Helfand is a highly regarded urologist with expertise specifically in prostate cancer, particularly in the area of genetics and genomics. He's a surgeon scientist, pretty cool, PhD, MD, with an international reputation for his research in prostate cancer genetics. Dr. Helfand is Division Chief of Urology and the Director of the John and Carol Walters Center for Urologic Health at Endeavor Healthcare, North Shore Healthcare, and that's up north. I worked there for about 12 years with Dr. Helfand and his amazing team. I got to be honest with you. I believe he is the best prostate cancer surgeon in the world. And he is a friend of mine. So as much as I wouldn't want him up in my junk, I'm telling you, if I had to have the surgery, this is the man I would go to, because he has a completely unique team and approach to prostate cancer. He has people who address sexual health. He has a nurse navigator. He has a full team of people who are there to help you navigate your way through prostate cancer, which is the way it should be everywhere. So I'm so proud to have my friend and colleague and welcome Dr. Brian Helfand. I'm so glad you're here this evening. Thank you for joining me.
Jeff, that couldn't have been kinder. And certainly a lot of what Jeff was really referring to was really the vision that was created by Jeff himself, and just understanding how important it is to address all aspects of prostate cancer care, including, obviously, and very importantly, all sexual function and the relationships that surround it as well. And so certainly, again, emphasizing just that vision itself, you would think should be standard and commonplace, but really was not and continues to not be in many places. So kudos to Jeff, and really creating an environment that was just awesome for me too, and continue to work at. So thank you for that. And I think really that's why I'm here, and why prostate cancer is so relevant to all of these viewers. And it's largely because prostate cancer affects so many people with prostates, right? It is the most common cancer that men get. About 1 in 8 men in this country will get prostate cancer throughout their lifetime. And again, that isn't, as soon as you start talking about prostate cancer, you will start seeing a lot of people start chiming in. Oh, I know someone with prostate cancer, or I had prostate cancer, et cetera. So the universal influence on everyone's lives, and now including our former president, it really touches all of us. And so it's not just cancer, right? And I think that that's really some of the absurdity or unfortunate part about prostate cancer is that there are many cancers that you just go after that cancer and then you're done, and it really doesn't influence or impact other aspects of your life. But the prostate itself is located in the worst part of the body. So for those of you who don't know, the prostate is situated at the bottom, the base of the bladder. And it's what men pee through that ultimately is an important part of urinary function because it normally sits there and acts as almost a secondary valve or sphincter muscle that really can help control your urine. But also, as shown in that slide there, it's right around there is all the good stuff that we really like. Again, the other muscles that keep you dry and help you urinate, as well as all of the nerves that control your sexual function, your erections. And the prostate itself, its normal function is that it makes all of the fluid for ejaculation. So it's what keeps the sperm happy. So when you think about normal physiology of how everything works, are that sperm that are necessary for reproduction live in are made in the testicles, and then they're transported out ultimately through a tube called the vas deferens, which meets up with the prostate. And it's in the prostate where those sperm are connected with all of the fluid that is important for keeping those sperm happy. So the prostate makes about 95% or more of the fluid that is ultimately released during ejaculatory or orgasm. And that's really what the prostate's main function is to keep those sperm happy and to produce that fluid which protects them during theoretically their journey to the egg for reproduction. And the point there is the prostate is necessary for sexual health and reproduction. It also, again, acts as a secondary kind of valve or sphincter that helps control your urination. But that's really good if you are young and fertile and trying to reproduce. But certainly after reproductive years, the function of the prostate becomes less and less important. And in fact, it rather causes problems because it either enlarges, and I think you heard Dr. Glasser last week talk about as that prostate enlarges, it often impinges or squeezes on the urethra, the tube that we void out of, and that causes a lot of urinary symptoms. So that causes the frequency, the getting up in the middle of the night, which is also bothersome and can influence sexual activity as well, but for very, very different reasons. But importantly, it also can get prostate cancer. And so again, it's a very kind of cancer, a common cancer. And I should also note that because Jeff had that slide up, is that most of prostate tumors really happen in the outside of your prostate. So if you think of the prostate like an orange, about 90% of prostate tumors will form in the peel, what in this slide is called the peripheral zone. And then the part that grows and kind of obstructs and causes urinary symptoms is really that red part and that blue part called the transition zone, and a little bit of the central zone. So that's going to cause your urinary symptoms, but it's that peripheral zone, the outside, the peel of the orange, that most likely contributes to and forms prostate cancer. So that's really why when we talk about screening for prostate cancer, that we often will include a digital rectal exam because it's on the outside, so it makes it more easy in certain men to feel a lump or a bump on that prostate. And that's really why we are feeling for the prostate. But on the other hand is, again, if you're talking about just enlarged urine, enlargement of the prostate, that more often through aging causes urinary symptoms. So an important distinction there. Now, it is important that we screen for prostate cancer. And this is something that has really been a hot topic of debate over the past several decades. And, to those of you who are listening in, you said, well, screening for cancer, that's really important, especially because prostate cancer continues to kill about 30,000 men a year in this country alone. So you would think that screening should be given to everyone at all times and maximize the potential to prevent or find prostate cancer before it's causing a problem. The reason why screening becomes of such debate is that it takes a long time for prostate cancer to develop, meaning comparatively, and this is all relative, that most prostate cancers tend to take a long time, on the order of years to develop, and certainly then years to spread or go on to do bad things. So that's really quite ideal in terms of if you're going to screen a patient population, is it gives you ample opportunity to find and diagnose those prostate cancers. The problem with screening, and we can get into this more, is that sometimes our screening is so good that we have found and historically have gone on to treat a lot of men whose prostate tumors are so slow growing that they ultimately would never have gone on to do anything bad. So what do we talk about when we talk about screening? First of all, it's important that every listener understands that prostate cancer screening means that we take a population of individuals with prostates who are totally asymptomatic, meaning that they're going about their everyday life. They don't have any symptoms from prostate cancer. Well, what are symptoms from prostate cancer? So men who have advanced prostate cancer, really bad type of prostate cancers, can have obstructive urinary symptoms, meaning they have a really weak stream and it's difficult for them to empty their bladder. They may have blood in their urine. They could have bone pain or weight loss. But this, in today's era where we're usually screening men, really doesn't happen. And again, remember from last week that the most common cause of urinary symptoms is not prostate cancer, but rather it is because of benign enlargement of the prostate that occurs in almost every guy. So I don't want you to leaving here thinking that, hey, I have urinary symptoms, therefore I have prostate cancer, but rather most likely you do have symptoms related to benign enlargement. So again, when you talk about then screening, we talk about men who really have mild symptoms, really no urinary symptoms, no bone pain or weight loss, and they're going to see their physician. Now, the current recommendations for average risk males, and what I mean by average risk is they don't have certain risk factors that we know of. And there are so far and few between. We know that older men are more likely to have prostate cancer. So older age is a risk factor. But you know what? We can't control that. And you know what? God bless us all. I hope we all get to the point where we're old and aging, et cetera. So that is one of those we acknowledge, but we can't do anything about. Certainly, male sex is another one. That's another thing that we don't have control over. But if we have a family history, that is certainly a known risk factor. So if your father had prostate cancer and your brother or the first degree relatives have prostate cancer, you are at increased risk statistically of being diagnosed with prostate cancer. These days, we also have recognized that it's not just prostate cancer, but many other cancer types in your family can also increase your risk, meaning that if you have a family history of breast cancer, ovarian cancer, colorectal cancer, pancreatic cancer, lymphomas, etc., that may also be associated with an increased risk of that you have susceptibility to prostate cancer. So it is important that you know your risk. So do talk to your families. Do try to find out if there are any other cancers in your family. And if there are, what are the age of diagnosis of these relatives? Meaning that the earlier that they were diagnosed either with prostate cancer or some of these other cancers, the more likely you would be to be diagnosed at earlier ages. And certainly pay attention to not just prostate, but pay attention to many of these other cancer types. In light of that, other screening risk factors that do reflect the family history are certainly genetic mutations. We do know, and this is a lot of what I study, that there are certain genetic mutations that increase your risk of prostate cancer. So what are genetic mutations? Why do we care about them? And why should you care about them? So understanding your DNA, and again, this is what we call germline DNA, or this is the DNA that's passed from generation to generation. Again, you had no control over it. This is what both your parents, your mom and your father, provided to you. And this is what you have the potential to pass on to any offspring that you have. And this type of genetics, you can have different genes within your DNA that are mutated. And these type of mutations can increase your susceptibility to prostate cancer. Now, again, understanding your genetics does not, and if you had a mutation, does not mean that you will definitely get a disease, right? So what I mean by these mutations are that increases your risk of getting that cancer. So if you have an increased risk of a certain disease like prostate cancer, that should influence your screening behavior, meaning that, as an example, if I had a mutation in a gene such as BRCA2, which many of you may be aware of because of its association and increased risk of breast cancer, that can increase your risk by about 3.3-fold for being diagnosed with prostate cancer. So understanding that would say, hey, I have that increased risk. I can't do anything about it, but it's not an absolute, but if I certainly have that risk, that I should start getting screened earlier for prostate cancer. So I can have that conversation with my care provider. He can potentially do a genetic test. And by the way, to get tested to see if you are a mutation carrier, all it is either a blood test that they can send away, or certainly a saliva kit. You can even spit in a tube and they can analyze your DNA that way. So it is one of those where it is important to get tested. And I don't expect you guys to know the names of all these genes. I think people start going to sleep. But I think, as just highlighted there, whether there are genes such as BRCA1, BRCA2, HOXB13, ATM, CHEK2, etc., that all have associations with prostate cancer. So understanding that is power because it allows you to make better decisions, talk to your care provider about it, and help identify when you should be screened. Now, because this is a podcast and I can probably talk a long time about it, we can go into the details of a lot of this testing. But I think the other important part of genetic testing that we can also examine that have really started to come into the scene, not only for prostate cancer, but other disease states as well, are things that we call polygenic risk scores. And that is a total mouthful. But polygenic risk scores are based on the presence, again, in your DNA, the DNA that's passed from generation to generation, called germline DNA. And what they do is that there are obviously, your DNA encodes provides instructions that tell you who you are, right? And everyone has unique instructions. And there are various, if you will, blips or variations in those instructions that truly make you unique. And certainly a lot of these blips that I call are all have a technical term. They're called single nucleotide polymorphisms. And there's millions of them within our DNA. And if you would believe it, there are various single nucleotide polymorphisms, or blips, if you will, that you can identify and count up, and they increase your risk specifically for certain diseases. So there are single nucleotide polymorphisms that increase your risk of prostate cancer. There are others that increase your risk of diabetes. There are others that increase your risk of heart disease and colon cancer, etc. And over the past, again, several decades, we've not only identified that these things exist, but we have the ability to count up how many of these blips or single nucleotide polymorphisms that you have for a certain disease and create a score called a polygenic risk score. And again, it's really easy to interpret because if you count up the number of them and then do a formula based on how many there are and how much effect each has, you can create that polygenic risk score. And if you had a score of 1, that means you would have average population risk. And again, stated for prostate cancer, that would be about a 1 in 8 chance of being diagnosed with prostate cancer. But if you had a polygenic risk score equal to 2, that means you're 2-fold higher, or about a 1 in 4 chance of being diagnosed with prostate cancer. And also on the other end of the spectrum, you could have a score like 0.5, saying you're about 1/2 that risk, and saying that, hey, your actual chance is only 1 in 16 throughout your lifetime. So this is where it's becoming very useful because those polygenic risk scores are very important. So for prostate cancer, those polygenic risk scores explain about 40% of why men get prostate cancer. And everyone has their own unique risk, right? So it's not a general statement saying, hey, I had a father who had prostate cancer, therefore my risk is 1.5-fold higher than the average population. No, this is a personalized score based on the number of variations that you have. And basically that can tell you your risk of prostate cancer. And certainly your score is also correlated with the age of diagnosis. So the higher your score, the more likely you're going to be diagnosed with prostate cancer at earlier ages. And the lower your score, the more likely it's going to be later. So there you can see the opportunity. You can adjust someone's screening habits, meaning if we're going to start testing for prostate cancer, that you can personalize their screening approach. So if you're a higher score, you're going to want to be screened earlier. And if you're a lower score, you're going to be screened later. So it is one that I'm really excited about, because the combination of testing for a panel of genes like the BRCA genes, and also testing for these polygenic risk score for prostate cancer, it truly enables us to personalize your screening habit. Because many of the other risk factors, aging, male race, I forgot to also mention that, sorry, male gender, but I forgot to mention Black race is also an increased risk of prostate cancer. Black men have over twofold higher risk of being diagnosed. So again, these are all things that we don't have a lot of control over, but being empowered and making the decision of if you want to get screened for prostate cancer and when to start screening is a lot more useful. And that's where this genetic testing really comes into play. So I'm really, really excited about that. And I think we're seeing that starting, certainly at our own institution, but at many other sites throughout the country. These polygenic risk scores are now being more commonly used in cardiovascular disease, but I think very soon you will see them very commonly implemented for your prostate cancer screening decisions. Now, if you're going to have that conversation, and I encourage you all to reach out, or at least if it doesn't directly relate to you, encourage your family members or friends or partners or spouses who are interested in undergoing prostate cancer screening to talk to their providers, right? Again, having that conversation empowers that patient and allows you to make the informed decisions of the next steps. So what do I mean by prostate cancer screening? Prostate cancer screening itself involves really two components. It involves, number one, a blood test known as the PSA, or prostate-specific antigen. Prostate-specific antigen is the most common blood test that we use for prostate cancer screening. In and itself, PSA is a protein that is secreted from the prostate. As the slide is showing here, it encodes an enzyme, a protein that basically helps to make the ejaculate, the fluid that we expel during orgasm, more liquidy. And so one of the PSA itself is prostate specific in that it's mostly produced in the prostate, is normally utilized to help in reproduction and liquefy that fluid. But it turns out that if you have a lot of cells, like cancer cells, that are actively dividing, and it is making a lot of proteins in the prostate, PSA expression or release of that protein into the bloodstream becomes more common. And that's why we use it in prostate cancer, because there's a lot more PSA production there. So you can see higher rates of higher concentrations of PSA that we can measure. Now, PSA itself is not a good test. It is the most common, but just because everyone's doing it doesn't mean that it's a great one. And the reason why PSA is not the best test is that, number one, that PSA is not specific or sensitive only for prostate cancer, meaning many other conditions can also influence your PSA levels. So that could be cancer. Yes, that's what we're most worried about. But other things such as an enlarged prostate, inflammation, prostatitis. I think you heard about this all in last week's episode. It could be sexual activity. The more you stimulate a prostate, you may release more PSA levels. Activities including exercise, cycling, have all been implicated in higher PSA levels. So again, just because you have an elevated PSA does not mean that you have prostate cancer. The other thing that somewhat plagues PSA is that it can be elevated for all prostate cancers. So it's really sensitive in that it can identify many men with prostate cancer, but those can be very indolent, kind of very slow growing tumors that may ultimately never go on to harm a man, or it may be, a very advanced or aggressive form as well. And certainly, not to make this picture even more doom and gloomish, but there are some guys who have really, really bad aggressive type of prostate cancers, and their cancers are so differentiated, meaning that they don't even look like the prostate anymore because the cells are so advanced that they don't produce a lot of PSA. And so that's where PSA as a blood test can also fail us. So it's important that if you have an abnormal PSA, that you would get additional testing to help validate it. Now, again, things to remember about prostate cancer testing with PSA is that in itself, it's not a great test. And just because you have an abnormal value, an elevated value, doesn't mean that you have prostate cancer. So if you get an abnormal value, you should definitely repeat the blood test one more time before a further workup is recommended. And again, the reason why that is there are so many confounding variables there. And in fact, if you really want the truth, the PSA value can fluctuate about 30 to 40% on a daily basis. So again, if you, number one, are told that you have an elevated PSA, make sure that your provider repeats it to ensure, validate that you have an abnormal PSA. If it goes down, continue to follow you. But if it's the same or higher, you may want to get worked up further. So what is an abnormal PSA value? PSA itself, again, I think in medicine, you always want to kind of fit in. You always want to be like your age colleagues. So what are the typical values that men have? Well, according to our current guidelines recommended by the American Urologic Association, we shouldn't start men screening for prostate cancer until age 55. Again, this may be modified based on your risk factors. So if you had an elevated polygenic risk score, or you have BRCA mutation, or you had a family history, you may start earlier, up to 10 years earlier. But for average men, they would start at age 55. And if you looked at the median PSA, so essentially the average PSA value for men who are in their 50s, it's about 0.9. When men reach their 60s, it's about 1.3, and their 70s, it's about 2.2. So again, I'm not asking you to memorize these values, and just because you're above those thresholds, remember, it's not like you have prostate cancer, but if you're above those thresholds, it's important that you should consider at least annual regular screening tests to just follow the trends over time to see how they are going. And certainly if they progress, meaning they continue to rise over time, you may want to work it up further. Additionally, as part of that screening, that you should also be getting a digital rectal exam, so a feel of the prostate. Again, this has somewhat become controversial, and a lot of internists, based on their guidelines, have stopped doing it because the internal medicine doctors, the family care physicians, don't necessarily in their studies have the best appreciation if there's a lump or not, and it's just the regularity that they do it. But certainly most urologists will continue to feel the prostate to assess if there's any bumps or nodules there, a firmness there. And so again, that's just another way to detect if there's a local growth, because as I said earlier, that 90% of prostate tumors will form in that orange peel, the periphery of the prostate, which you can feel from the rectum, because the prostate lies just below the rectum and it's easy to feel. So if you have an abnormal PSA value And a lot of primary care physicians, again, don't necessarily adjust for age. They just use a value of 4 as a cutoff. So if you're higher than 4, or certainly if you have an abnormal digital exam, then you can consider further workup. Now, the way that is worked up, unfortunately, is still, if you will, not standardized throughout this country. So there's a lot of things that you can do additionally. So there are other secondary blood or urine tests that measure other proteins that can help distinguish prostate cancer a little bit better compared to other benign conditions that we talked about, like an enlarged prostate or inflammation. Some of these tests, as an example, the Prostate Health Index or the 4K score, or there are now other urine-based tests, are available that offer better distinction between these type of conditions. And again, I'm not going to get into the nuances of these type of tests, but they certainly perform better than PSA at identifying men who are more at risk or likely to have prostate cancer. And some of these, like the Prostate Health Index or 4K score, can help even distinguish if you would have the presence of an aggressive tumor, the kind that ultimately may have potential to spread outside your prostate or certainly go on to do bad things. So these supplementary or secondary biomarker tests that we call them, I always offer my patients, because if they are low risk, then we would avoid the next step, which would be consideration of a biopsy. Now, in today's era, most physicians, urologists, before they go to a biopsy, should consider doing a prostate MRI. Prostate MRIs are still, I would call standard of care these days, but they're still a consideration in our guidelines. They are a fancy picture of your prostate. They do involve, number one, sitting in that tunnel. So I do understand that a lot of people are claustrophobic and don't enjoy being in that tunnel. I personally do. I think it's a nice, quiet place. On the other hand, is that if you are claustrophobic or have other fears, certainly there are ways that you can bypass them, and certainly that can often just be an anxiolytic medication that can make you more comfortable throughout that procedure. When you lay in that tube, it's about a 40-minute exam. So it is some time of you just laying there. But during that time, they image the prostate. They do give you contrast material called gadolinium through the IV. And the way that the prostate picks up that contrast, and certainly then the way that it diffuses or goes away, you can tell the likelihood of there being cancer in a specific area of your prostate. Now, again, the MRIs are not diagnostic unless you had a really bad disease and you can obviously see that it's spread throughout your pelvis. But most men who are undergoing these type of MRIs have totally normal looking MRIs, but there are areas that are in your prostate that have a higher likelihood of harboring prostate tumors. So that allows you to target them during a biopsy, because you can actually see it and then ultimately use those pictures during the biopsy. On the other hand, is just because you have a target there does not mean you have prostate cancer, but rather it just helps as an image that makes those biopsy results more accurate. So if you are told that you've had the MRI and there's what's called a PI-RADS score of a 3, 4, or 5, those are the ones that we say, hey, we should sample them with a needle to see if there's cancer present or not. Again, I cannot emphasize enough that if you have one of those lesions, it does not mean you have cancer. And oftentimes there are still false positives, meaning that you can have a target, but no cancer present in that area. If you get an MRI and if there is a target, then you should undergo a fusion biopsy. And all that just generally means is that you have the time during your biopsy. You have an ultrasound that is used, usually a transrectal ultrasound that will image your prostate in real time. And then with that, they will call in those MRI areas, the MRI images that have already been processed by the radiologist, and marry those images together or fuse them together. And that allows us during that biopsy to target certain areas of the prostate. There are so many variations these days on the biopsy, but the two main forms of a biopsy are a transrectal and a transperineal approach. In the US, there really is no difference between the two approaches that have been described. Transrectal means that as we image the prostate, we take a needle through that transrectal ultrasound probe, and then we pierce the rectum and then directly go into the prostate. In and itself, it does not spread prostate cancer, but historically there was a concern that it could increase your risk of serious infections. And certainly in Europe, where things are not potentially as monitored as closely, there continues to be a somewhat higher rate of infections after biopsy. So therefore, the second approach, called a transperineal approach, is often utilized. It was initially thought that maybe transperineal was even more accurate, but actually our randomized trials in this country really show no difference in accuracy there. Transperineal is different in that what it does is it inserts a transrectal ultrasound probe, a slightly different one than the one that was initially described in the first transrectal method. But this probe allows you to image the prostate. But then instead of putting your needles through the rectum, it'll actually allows you to insert the needles underneath the scrotum through the perineum into the prostate in a longitudinal fashion. And so certainly there is a potential for decreased risk of infection because you're not piercing the rectum. On the other hand is when you compare the methodologies in this country that are utilized, there really is no difference in outcome. So it's really what's more comfortable between you and discussed between you and your urologist. But certainly you should bring that up as a method, as a offering as a point of discussion with the urologist to ask him what he prefers, why he prefers it a given way, because as far as I'm concerned, it gets us the information one way or the other. And again, the transperineal approach is very accurate and does not spread cancer either. Now, once you have the biopsy, you actually may be told that you have prostate cancer. Again, just to go back there, a biopsy itself is a very well-tolerated procedure. It often takes about anywhere between 5 to 20 minutes max in the office. Certainly, you can also have it done in the operating room, but most men will tolerate this in the office without any problems, with no additional anesthetic other than local anesthetic with lidocaine delivered to the prostate or into through the perineum, but very well tolerated and very quick. During those procedures, there's usually anywhere between 12 to 20 or more snippets, or what we call cores taken of the prostate, samplings of the prostate. Again, we normally sample the peel of the prostate, but in addition, if your MRI is positive, we will also oversample those regions. Now, if cancer is found, the pathologist will review that, and usually within several days to a week's time, you may get a call saying that you have prostate cancer. Now, if you are told that you have prostate cancer, it's important that you understand the Gleason scoring system, or the Gleason score. Now, the Gleason score is really just our way that the pathologists communicate to us how aggressive or non-aggressive your tumor is. So in order to get a Gleason score, that means that you have prostate cancer. And then they give it a score on a scale really between 6 and 10. Now, 6 is what we call a low risk or non-aggressive cancer, and a 10 is a very aggressive or high risk cancer. Low risk 6 means that it has a low potential to spread outside your prostate and a low potential to ultimately go on to kill a man. But if you have a Gleason 9 or 10, that means you are an aggressive tumor, or there's a high risk type of prostate cancer, meaning that left to its own accord, it has the ability to higher chance to spread and go on to kill a patient. As an example, former President Biden was just diagnosed with a Gleason 9 type cancer. This is a more aggressive type cancer. So this is really why that he would require treatment or therapy. But the way that we ultimately decide on how patients are treated is truly based on how aggressive their tumor looks. So again, if you are a low risk Gleason 6, or it's going to be treated very differently because it has a low risk of spreading outside your prostate, versus if you have a high risk, very aggressive type of tumor, you're going to treat it a completely different way. So we personalize or cater that treatment based on how aggressive that tumor is. Now, it's important to understand that men who have low risk prostate cancers, Gleason 6, or even some Gleason 7, what we'd call an intermediate risk cancer, that again, they are so slow growing that we often will follow them over time. That form of following that type of treatment is what we call active surveillance, where we actively monitor patients over time, not because that low risk tumor will ultimately go on to do bad things, because again, I just said it's low risk, but because those men can form another tumor in their prostate that may have more aggressive potential to go on to do bad things. So to prevent that latter scenario from happening, that we actively monitor or follow them over time, meaning what does active surveillance mean? Is that over time we follow regular PSA like blood tests. In our clinic, we use the Prostate Health Index, or the PHI. That's what I mentioned earlier as a supplemental test. But that also has utility in active surveillance monitoring. So we monitor that value on a biannual basis. We also do repeat biopsies over time. Again, about every 2 to 3 years, we resample the prostate to make sure that there's not a newer type, more aggressive tumor that forms. Active surveillance is considered the standard of care for many men, if not all men, with low risk prostate cancer. On the other end of the spectrum is that if you have a higher risk or more aggressive type tumor that is confined only to the prostate, meaning it hasn't spread the best we can tell and is localized only in the prostate, that's really where we start talking about more radical type of treatments. Radical meaning that we would treat the whole prostate, and we can either treat the whole prostate with either surgery, where we remove the entire thing, what we call a radical prostate or prostatectomy surgery, where again, we remove the whole thing, or we radiate the prostate, and where we complete that radiation, AIM beams of radiation. And there are so many different flavors of radiation, and that's a whole nother topic of conversation that we can discuss at some point, that we would eradicate or treat that cancer as well. Now, sometimes that radiation is also paired with medical therapy for short periods of time, where we would starve those tumors of their main food source, which is testosterone. Again, starving the prostate tumors by giving you drugs that block testosterone is an effective way to manage as well. So those are really on the opposite ends of the spectrum, meaning that you have on one hand men who have lower risk tumors, which are so slow growing, we are just actively monitoring them. And if they would ever progress, we would intervene at that time and say, hey, now you're a candidate for surgery or radiation. On the other end is that if you find men who have prostate tumors that are more aggressive, higher risk disease or higher volume intermediate risk disease, then that's where we start offering radical surgery or radiation. Now, there is kind of a newer modalities, and there's a lot of different ones in here as well, where we talk about focal therapies. Now, focal therapies are not standard of care. Let me repeat that. Focal therapies are not yet considered the standard of care. On the other hand, they are often utilized for men who have lower or slightly intermediate risk Gleason, what we call Gleason 7 type of prostate cancer that appear to be confined to just one or two areas of the prostate. And the thought there is that if you would just treat just those areas of the prostate focally, that you could prevent some of the potential for side effects that you can get with radical therapies. So I did not mention, because it is not a definitive, but often men who undergo radical therapies with either surgery or radiation may have an increased risk of side effects. It's not surprising because is that if you do something, especially something radical, there is a possibility, not a guarantee by any means, that you could have erectile dysfunction. You could have urinary leakage or incontinence. You can have bowel issues there. And so it is one of those where while all of these technologies for surgery or radiation have significantly improved over time, I think the robot that is used for radical surgery is now in its 5th generation. It talks to you, it's very cool, and they're designed to really mitigate or minimize side effects, but they still can happen. So if you had a lower risk type tumor, and you said, well, you know what, I don't need to treat the whole thing because it still has some aggressive potential, but not a whole lot of potential to spread outside your prostate, then consideration of focal therapies may be appropriate. And again, the point there is if you just treat part of your prostate, that decreases the risk of you having any of those side effects that you would have if you treated the whole prostate, like with surgery or radiation. So your risk of leaking urine or erectile dysfunction and improvement in overall quality of life remains there. And again, these days, whether we're talking about a newer therapy such as aquablation that is currently being studied in this space, or whether it's using ultrasound waves or electrocuting part of the prostate, there are so many ways to destroy part of the prostate, but minimize those risks of side effects. So I think if you are unfortunately diagnosed with prostate cancer, it's important to understand, number one, how aggressive it looks in the microscope, know your Gleason score. And two, based on that Gleason score, based on your PSA, based on your overall health, your other medical problems, there's so many things that factor into that. It's important that you sit and you have a very heart-to-heart, but truly spend time talking to your urologist about what are your available options. It's important that you understand and encourage, get a second opinion. Because everyone may look at it slightly differently, but understand what your option is. Certainly find someone that you trust, find someone who has not only the experience, expertise, who is really focused in on treating prostate cancer. Again, all studies have shown that you want to be treated by someone who does it over and over again. This is true for prostate cancer, but frankly, this is true for most things, right? Is that even if you had a kidney stone, you don't want to go to someone who dabbles in kidney stones. You want someone who treats it all the time. There's no difference here because the risk of you having side effects or problems, no matter if you're just following it and doing biopsies, if you're undergoing radical treatment, is going to be a lot lower among or with practitioners who are familiar and do it all of the time. I think also, and this probably moves beyond the scope, and I keep talking here, so I probably have more than used my time, but it is something that you also want to feel supported throughout this process. Obviously, even though it is still a slow-growing tumor, even aggressive forms, it still requires a lot and has the potential to impact a lot of aspects of your life and quality of life. And so having that support, having a urologist that has that connections with other support members, team members, whether that's psychologists to help with the emotional support that you have cancer, whether that's sexual health, because the cancer treatments have that potential to impact your sexual health, or whether it's reconstruction urologist that if in case you did leak urine, that they would know how to fix it. Having all of these, and these days I believe in having a dietitian as part of it, and truly a multidisciplinary team. So involving all of these people is really a necessary part to really a successful, I think, program. Because again, there are so many various aspects that ultimately may be impacted along that journey, and having those resources at your fingertips really does help care for the patient as a whole. And so with that, I don't want to continue to overstate my my mainstay here, or my welcome, I should say. So certainly, Jeff, I know that there's probably other questions out there or things that have been brought up.
Awesome. Thank you. Lots of information packed in there for sure. So a couple things that I was thinking about, and I do agree, I think what's unique about your center and it is that it's from the beginning and concept. And I know that was from our predecessor who brought us on board there, Chaz Brindler, who kind of wanted this personalized patient-centered care. And I think that's so important. And you emphasize that really well. And I think where maybe the listeners, you may be like, well, I don't understand, why not get rid of the cancer, eradicate it at all costs and everything. But the reason a lot of this is controversial and that we're talking so much about it is because when the more you do, the more radically you treat this, the more potential there is for quality of life side effects like sexual side effects and things like that. And so, yes, we live in a country where we're like, get rid of the cancer. It's a really big deal. But we also want people to have quality of life too. So it's a balancing act of finding the right thing. And that's why I love how you emphasized you need to know yourself, and your doctor needs to know you well to know exactly what's important to you and what's going on so that they can help you make the best choice of how to move forward with treatment. Everybody's situation is so different. So your Gleason score is important. So many different, your PSA number at diagnosis, so many different pieces fit together to help you navigate your way through this. And so it can be really challenging. So this first question came, and I think it's a good one that kind of addresses that. As I continue to navigate, and I run a prostate cancer group at Gilda's Club for Zero. So it's really difficult navigate my way through determining my initial prostate cancer treatment. What are some of the important things I should make sure my doctor understands about me before proceeding with my prostate cancer treatment?
Yeah, I think it's so important because, again, we are so moved away from the concept that I have cancer, we just need to stamp it out and eradicate it. Really, everything is truly personalized for that patient. So I think number one, at basis, this is what a physician should know anyways, but of course, in the real world, that's not always true. But they should understand, certainly your other medical comorbidities, right? So that if you have a lot of medical sicknesses, you shouldn't necessarily even be screened because, again, it's just competing mortalities based on those other illnesses that you may not need to be screened because the other things you have may be more severe. But beyond that, I think it's important not only understanding that, but also in that concept, I should also make sure and say, if you are considering doing surgery, make sure that you have a full understanding of other surgeries that you may have previously had, because again, things that you've had in your belly, like bowel resections or inflammation from colon disease or diverticulitis or things like that, are important to bring up to your physician just to help plan that more appropriately. It doesn't mean you're contraindicated for surgery. It's just one of those where it's just important to verbalize that. I can't tell you how many men kind of forget to tell me that they've had their surgery, even though I've asked them about it. So it is one of those as a reminder to kind of bring up. But the other part about that, and the really sincere part about that, is it's important to have these conversations about your goals. And I don't just mean cancer goals. I think everyone is truly has the same goals to treat or control this prostate cancer to the best of our abilities. On the other hand is, the thing about prostate cancer is you're going to be around. You're not dying anytime soon. And so you have to live. And I think the whole point of living and life is to enjoy it and fulfill it. And if you are going to feel that if you had a side effect, that it's going to stop you from living, then you're not going to want to do that therapy because, again, and so relaying the importance of leaking urine and understanding what those risks really are, or understanding how important it is that you maintain your ejaculation or your erections or the fluid that comes out. That is all something that should be discussed because, again, you are going to be around. And I think, again, you want to be able to live to the best of your ability to enjoy life. And yes, our values and the importance of things change as we age. So we can't always account for that. But the best that you can predict and the best that you know yourself at that time and how you can tell your physician about it is really important because it does influence the way that we treat you.
Yeah, answer, but you got to pick the right one for you. And it's often caught very early because of screening and things like that. So screening can be important. And then again, even as you get older, so starting at 55, like you said, but as you get older, they stop screening a lot of times when you reach a certain age because prostate cancer is not going to take you out at those later ages if you haven't had it up until then. So there's just so many factors for you to think about, listeners, as you're thinking about this, for you to really think about in your particular case and work with your doctor on what you want to do. And what I think so amazing about your clinic is, and this really says a lot about you as a surgeon, is that before they even go into surgery, they meet with an advanced practice nurse to already get on top of and talk about sexual function, to learn how to do the pelvic floor Kegels, and to be prepared for those quality of life altering side effects that may come. You're anticipating before they even go in, you're helping them anticipate and be ready and do everything we can to manage those things. And this one patient said, why doesn't everybody do it like this? And I said, I don't know, but this is the model that we have at Endeavor North Shore. And I think it's a good one for everybody to do, but it's pretty cool.
We may be biased, but I think it's pretty cool.
It is. Well, I'm retired from there, so I'm not even, you can't even say I'm biased because I don't work there anymore. I work at the VA now. So I always worked at the VA for that time too. But anyway, here's another question that came in. Question 2 is, I've heard they can do some testing on my prostate cancer tissue to better understand how I might respond to treatments for recurrent prostate cancer. Can you help me understand how that might help?
Yeah, so that's kind of comes in several forms. So your tumor tissue contain a lot of different signals, right? So there's a lot of proteins that are expressed, and as we talked about, there's DNA in that tumor as well. And you can analyze that, and we call those genomic tests. And most of the genomic tests, and what I refer to that are the most common one these days is called Decipher, but there's also other ones like Prolaris or Oncotype that you can take tumor tissue and extract a protein or an RNA, same kind of thing, a protein signature that can predict your response to certain events, how aggressive it is, what is your response to potential response to hormone therapy or radiation therapy, et cetera. So it is one of those where we often will send those just to get that additional information to help better guide your prognosis in terms of the chances of it coming back, recurrence, or certainly the chances of you, if you did need other therapy, of how you would respond to it. So those are pretty cool. And then these days there are also what's called somatic DNA tests. So I think I previously talked about the DNA that's passed from generation to generation. You don't have any control over it. Somatic are also you have no control over, but those are DNA changes that are specific only in the tumor, meaning that the other cells in your body don't have the same DNA mutations. These only accumulate in the tumor itself as those cells rapidly divide. So we have the ability to analyze those tumors as well. And look for those similar type of mutations, whether that's BRCA2, whether that's ATM, et cetera. But those can help also predict our response to certain chemotherapies. So these days, there are drugs for men with advanced prostate cancer known as PARP inhibitors, certainly for men with other mutations called mismatch repair mutations that you may be responsive to immunotherapies. So again, knowing these type of mutations, especially if you have aggressive forms, really can help us better treat you, personalize those treatment. So again, really throughout that prostate cancer journey, from the time that we start, we're trying to implement tests that really help us guide us in terms of when we should start screening. And if you had cancer, who's going to benefit from which type of treatment. But certainly as that journey goes on, these other type of tests that are available to help us also personalize that experience.
Yeah, because I think it can be really scary. And just like for my patients in the group and my patients we see and the patients you see, you hear the word cancer and it just stops the world. And so I think helping them understand all these things, and that prostate cancer, it can be a very survivable cancer, especially when it's caught in these early stages. And so just really helping them navigate that, I think, is important. We've covered a lot of awesome material, and I thank you so much for all the information. I'm going to do a little centering exercise. We're going to talk about what's up next week and finish out the program. But so let's move to that. A lot of things to think about, lots to unpack, and maybe you heard the word cancer and that's why you're here tonight. Maybe you haven't and you're just thinking about screening. It's a very personal journey, and only you and your providers can help determine what's right for you. What's your next step in terms of screening, in terms if that's what you're looking at, or in terms of cancer care. So let's take a moment. You know how we do at the podcast. We find a comfortable position to get into. Sit comfortably, get your feet flat on the floor, get comfortable. If you feel safe doing so, gently close your eyes. Start by taking a deep breath in and slowly exhale. Let your shoulders drop, your jaw relax, your belly soften, your pelvic floor relax. Feel your body settle into this moment. Now silently repeat. Continue with those deep breaths. about 4 counts in, and slowly exhale about 4 or 5 counts out. Breathing is powerful. Breathe. Now silently repeat these affirming affirmations or truths. Why is it so empowering to take charge of my health? I deserve to prioritize my well-being. It is safe to ask questions and seek answers about my body. Continue that slow breathing pattern and take one more slow, steady breath in and exhale fully. When you're ready, gently open your eyes. Carry the sense of calm and empowerment with you as you move forward. Let's learn a little bit about what's up next week on Dr. Jeff Talks About Sex and Intimacy. Vic,
what happens when pelvic floor issues impact intimacy? In this compelling episode, Lisa Pear, NP, joins Dr. Jeffrey Albaugh to explore how pelvic floor dysfunction can affect sexual health, relationships, and overall well-being. Together, they unpack real-life concerns, clinical insights, and empowering solutions to improve intimacy and quality of life. Whether you're a patient, partner, or healthcare provider, this conversation offers guidance, hope, and clarity. What you'll learn: what pelvic floor issues are and how they develop, how these issues impact intimacy and sexual function, practical steps to improve pelvic floor health, advice for couples navigating these challenges. Don't miss an episode. Tune in May 27th at 7 p.m. Central Time.
Always crazy, but I like the chickens, but okay. Anyway, thank you so much. I can't thank you enough. Oh my gosh, for joining us and giving just an hour packed full of all kinds of information about the prostate and prostate cancer. So thank you for taking time out of your busy schedule. And I so appreciate the work that you and your entire team do over there at Endeavor North Shore.
Thank you, Jeff. Always a pleasure. Always a space for you. Always a home for you.
Definitely. It's so good to see you again. Always a treat. And thank you for joining me this evening. And thank you all, especially each of you, for listening and learning this evening. Have a great one.